Welcome, everybody, to the Cone of Shame Veterinary Podcast. I am your host, Dr. Andy Roark. Guys, I got a fantastic one for you today. I am here with the one and only Tasha McNerney, a.k.a. the original Anesthesia Nerd, and we're talking about reducing opioid use in our surgeries and upping our game with local analgesia. This is a really good conversation. We get down in the weeds about how do you actually do this, Tasha? I'm very open in this about concerns that I have about just going wild with locals and decreasing my opioids, and we really get into it. Anyway, if you do surgery, if you do pain management, I think you're going to get a lot out of this episode. It is really, really good. I talked to Tasha about her new book, Pain Management for Vet Techs and Nurses. She's the editor of this book. I don't want to take away from any of the people who are writing chapters. So it looks phenomenal, guys. I can't wait to get my hands on a copy of this. So anyway, that's what we're talking about today. Let's talk about local anesthetics, analgesics, and let's get into this.
This is your show. We're glad you're here. We want to help you in your veterinary career. Welcome to the Cone of Shame with Dr. Andy Roark.
Welcome to the podcast, Tasha McNerney. How are you, my friend?
I'm doing well, thank you.
I am so glad to have you here. I always love getting to hang out with you. You have been on the podcast many, many times. The last time I saw you, you were here in Greenville. We were going to a wedding together. We got to spend a weekend hanging out with your family, and it was absolutely joyful. We did not make any podcasts. I was like, we have to remedy that. And so now we're back. You have a new book coming out. And I was like, look, I dropped the ball at the wedding, but now she has a book coming out. Like, I have got to get Tasha.
Yeah, man. Why were we not talking about my book coming out at someone else's wedding?
Yeah, exactly.
Was the day about them?
Look, your self-promotion game is weak sauce.
It's terrible. I know. It really is.
Actually, no, it is. It's terrible. For people who don't know you, I said, okay, what is your official title? And you said, I am a co-administrator at Veterinary Anesthesia Nerd, which I said, it sounds like you answered a newspaper ad to get that job. You are the founder. It was your brainchild to create the Anesthesia Nerds. You have wonderful partners that you work with who do, I know you're so humble, but they have done so much work with your team to make this thing happen and to make it awesome. If you guys don't know what I'm talking about as far as Anesthesia Nerds, you need to check out their new website. It's beautiful. Their Facebook group has been around for a long time. But if you're interested in anesthesia and pain management and you're not in Vet Anesthesia Nerds, I really think you're missing something that's going to make you really happy. And so anyway, you and I met in Reno, you were just getting Anesthesia Nerds started. And so anyway, that's enough about us. we're going to talk more about your book in a bit. It's Pain Management for Vet Techs and Nurses, which is available for pre-order on Amazon. But I wanted to talk to you about something that you're out and you're talking about these days. And you're talking about the ERAS protocol and you're talking about local blocks. And so first of all, let's just start with the ERAS protocol and walk me through what is that?
Yes. If anybody has heard me speak probably in the last 6 months, they know that I'm kind of obsessed with ERAS and inevitably...
Not the Taylor Swift album.
No. Well, listen, I'm a Swiftie. I think that probably if anybody looks through the archives of our podcast together, we do have a podcast where for Halloween, I did record with you on Halloween. I was dressed as Taylor Swift in the cheerleading Taylor Swift. For you guys who knew the Taylor Swift, the discography and the legend out there, you know what video I'm talking about. But anyway, in the theme of ERAS, no, we're not talking necessarily about Taylor Swift. What I'm talking about with ERAS is something called enhanced recovery after surgery. And this comes from human medicine, and it has been around for quite a bit in human medicine. They actually started a group within the Anesthesia Society in Human Medicine all the way back in, I believe it was 2017 or 2016. And researchers started looking at ways that they could minimize opioids, right? So reduce opioid use, but while still ensuring that patients had a high level of pain relief. And then also putting in other things into the protocols to ensure that these patients were up and moving faster and just had a greater overall, better, enhanced recovery after surgery.
So when you start looking at this, okay, you're looking at vet medicine. And traditionally, vet medicine was pretty opioid heavy. It's a big part of our pre-medications, things like that. When you were thinking about ERAS protocol and you were thinking about how vet medicine, especially anesthesia analgesia, have been traditionally applied, what do you start to see? What sort of changes do you think will do the most good in vet practices, and what does that look like?
Yeah. So one of the key pillars, and there's a couple of different things that go into ERA's protocols in human medicine that we can take over into veterinary medicine. But one of the main things, kind of number one, is to be opioid sparing and to use what's called multimodal protocols. Now, probably if you've ever been to any anesthesia lecture in the past 10 years, you've heard about multimodal protocols. Right. You're probably already using multimodal protocols in your practices. However, what I'm finding is that these multimodal protocols, when they talk about them in the context of ERAs in human medicine, multimodal protocol always includes regional anesthesia or a local block, whereas that's something that I do think in veterinary medicine we could get a lot better at.
When we start talking about sort of local blocks, you have talked about this. I've had you on many, many times to talk about all different kinds of sort of local blocks and things like that. Are you basically saying, I don't want to oversimplify this, but should I be questioning myself if I'm starting to do any sort of soft tissue surgery and not be using a local? I mean, is that kind of where we are? Is basically, if I'm not using a local, I should stop and ask myself, why am I not using a local? And how do I need to use a local in the surgery? Are we at that level?
Yes, we are at that level. One of the key things with ERAs and kind of what I teach when I go out and start talking to people about how to build a good multimodal protocol is, kind of like when you're building that protocol and you're looking at that procedure in front of you. Let's say it's a spay, just for instance, right?
Sure.
So you're always kind of thinking, okay, well, what opioid am I going to use for this spay? What nonsteroidal am I going to give for this spay? What induction agent might I choose? Now, sure. I want you to also think, what local block could I use for this procedure? Again, whether it's a laceration repair, whether it's a spay procedure, whether it's a dentistry, there is a local block that we can use for almost every single procedure that we perform in veterinary medicine.
Let's say that I am your average small animal veterinarian. I do not have a local block for every procedure that I do, but I'm hearing you and I'm like, I want to be better. How do I start to build multimodal protocols that make sense? How do I get that education? Yeah, help me start to tomorrow do better for my patients.
Yeah. So there's a lot of information online. I mean, certainly our Veterinary Anesthesia Nerd's website has a lot of blogs and resources that you can look at. Within our new pain management book, we talk about ways to do multimodal protocols and how, we have a whole chapter just on all of the different local blocks that you could do. And you're totally right. There's all kinds of levels out there, right? We could be talking about something very simple, like an infiltration block, or what we usually call a line block, or even a splash block. Or if you really want to get fancy with your training and you want to kind of do that gold level medicine, you and your staff can go get trained in ultrasound guided nerve blocks, which is kind of like, as far as cool. That's pretty cool, right? So that's some stuff that they're doing a lot in human medicine that we're starting to follow now in veterinary medicine. It doesn't have to be that you have to go all that way, right? If you are a general practice and you're like, my bread and butter is just some spays, neuters, maybe some lumpectomies and some dentistries, there are plenty of local blocks that you can incorporate into those procedures that do not necessarily take a huge amount of extra training, and you don't need to do like ultrasound guided, right? We can do dentistry blocks for patients just going on landmarks. Same for infiltrative blocks, where we are just infusing the subcutaneous space along each side of the incision with local anesthetic.
So I imagine people hearing this and getting really excited, and they're just in surgery with a big, 30cc syringe of lidocaine, and they're just blocking this. You get a block, and you get a block, and you get a block. Okay, what constitutes a good block versus nonsense?
There's a couple of different studies out there, right? So certainly a really good block is one that if you have the ability to do it ultrasound guided or nerve stimulator guided, where you can make sure that you are actually depositing the local anesthesia in and around that nerve or bundle of nerves to prevent, right, that signal transmission from going forward. Kind of like with an epidural, right? That's kind of like the top of the line. However, we have these peripheral pain receptors all over. So even if you can and you do the splash block technique or an interperitoneal technique, you are still going to get some coverage and some efficacy. And again, any coverage or efficacy is just going to help contribute to you or your patient, meaning less overall opioids in the postoperative period, and intraoperatively, meaning less gas anesthesia. So anytime that we can do a multimodal protocol and rely less on gas anesthesia, that's going to be better for our blood pressure. That's going to be better for cardiac output. And similar to opioids, right? If we can do more of these multimodal techniques, more local blocks to cover, like we want the local blocks to be the heavy hitters for pain, not necessarily large amounts of opioids, because large amounts of opioids come with challenges as well, right? These patients wake up, they're kind of nauseous. For some patients, we have to worry about the decrease in heart rate or cardiac output if we have them on a fentanyl CRI or something like that. We have to worry about changes in their thermodynamics when they're on opioids. And we have to worry about like opioid dysphoria in the postoperative period. So anytime we can minimize opioids and kind of ramp up with other things, again, local blocks being a key component to that, it's going to give the patient an overall better experience. And we have some studies to show that not only are they up and eating faster, but they're discharged from the hospital faster, and the owners have overall greater satisfaction.
So I want to come back to that overall satisfaction, up and eating faster and things like that. In the moment, Tasha, like, how do you know this is working, right? You're a new vet and you're like, I'm going to start doing this. Yeah. How do I know that I'm making an impact? How do I know that my blocks are actually accomplishing things? You know, I'm assuming in human medicine, there's a pain score, and you ask the person, you know, what was your pain score and what's your recovery score and things like that. We don't really get that level of insight. How do you know that you're doing it right?
Yeah. Well, the nice thing is that we do have pain scoring. We have a lot of different ways that we can pain score postoperatively for acute pain. Now, you can utilize something as simple as the University of Colorado scale, which is available as a free download in a PDF that you can print out and put around your hospital and train your staff on. Or if you want to get a little more advanced and you want to utilize something that has been validated and researched, you can utilize either the Glasgow short form pain scale, or you can do, you know, if you have felines and you're doing feline heavy practice, utilizing the feline grimace scale, which has also been validated and is very easy to use and has a pretty handy app online as well for pain scoring acute pain in cats, which works wonderful post-surgically. And we have been able to see that patients who get local blocks, either, you know, our post-TPLO patients that before we may have had them on fentanyl CRIs for 24 hours post-knee surgery. Now with targeted local blocks, we maybe have them on one or two doses of an opioid post-op instead of up to 24 hours. So we are seeing it in real time, utilizing these pain scoring methods, that animals that do get these local blocks tend to need less rescue analgesia and have better overall pain scores in the postoperative period.
What's your favorite pain score and why?
Oh my gosh, like my favorite child. All right. So I think the Helsinki index is a really, really interesting one. But again, it takes a longer amount of time. So I don't know if it is as practical. So really, from a practicality standpoint, a acute pain score that every single practice can implement tomorrow, that's the feline grimace scale. Like the researchers in Montreal have outdone themselves with all the work they have put into that project and, you know, understanding feline acute pain. And it's chef's kiss to them.
I agree. The app is so cool.
Yeah.
And it's just, yeah. Anyway, all right. Just curious. All right, great. Talk to me about reduction of opioids. So I would like to use less opioids and I'm doing these blocks. How do I start to titrate down my opioids so I'm not having a panic attack the first time? You know, I'm imagining that we're probably not doing a certain percentage reduction, but talk to me about how you would work with a vet who's starting to use local blocks and things and start to actually turn that dial down in a way that everybody in the room is going to be comfortable with.
Yeah. So I also want to clarify, just to make sure that people know, that I am not talking about opioid-free protocols. There was some research into opioid-free protocols in veterinary medicine, and they did not, in the one study that was out, they didn't find a huge benefit to going completely opioid-free. So I just want everybody to know, I'm not talking about opioid-free or never using opioids. What we're talking about is just reducing opioids or being what they call opioid sparing, okay? We still want to use opioids, right? Because opioids are going to work on our when we think about the different pain pathways that our analgesics are working on, those opioids are going to work on modulation of those pain signals. They are going to work on patient perception of pain. So opioids are still an important component of your multimodal protocol. What we want to get away from, though, is just putting every single abdominal surgery on a CRI of fentanyl, or every single orthopedic on a CRI of fentanyl. When we have these targeted local blocks together with adjunctive analgesics, which we can talk about in a minute, when we're utilizing these things together, right, we're utilizing multiple drug classes to get the maximum amount of analgesia with the minimum amount of side effects. Because instead of just giving one whopping dose of fentanyl and then continuing with a fentanyl CRI, which is going to be problematic in its own right, we still want to use a little bit of fentanyl, but we also want to add in maybe a little bit of dexmedetomidine, maybe a little bit of ketamine, and our local blocks in there. And then we can keep our inhalant really low. So it's all about that kind of balance instead of just a sledgehammer of opioids, which I think that we have just been so dependent on opioids being our heavy hitter for pain. And again, this is not to trash opioids, but you guys, the more we start reading about some of the studies that are coming out in human medicine and how they are able to achieve really excellent analgesia without opioids, it's pretty fascinating.
Yeah. No. So talk to me about adjunctive analgesia then.
All right. So I actually kind of first started this kind of in my brain of looking at like, could we be doing things better? 'Cause I'll tell you, I am a CVPP, which is a designation given out by the IVAPM, which means that I'm a certified veterinary pain practitioner, which means I just love and have spent a lot of time researching and studying all things pain management, right? But I got invited to go speak at a conference in Moscow, and I went over to Moscow, and it was very, very cool. The people there were wonderful. They were so into kind of like, what are some things that you're doing in America that we could be doing better here, et cetera. I got to spend a half day at one of their veterinary clinics. And one thing that really stood out is that a lot of their surgeries had epidural catheters placed. And Andy, an epidural catheter is a pretty advanced procedure. And these were GPs, like a GP. And every one of their doctors and nurses on staff was proficient in these advanced local blocks. And so I started asking, and it turns out that their opioids are not approved for use in veterinary medicine.
Wow.
So they have to adapt, and they have to try to do good analgesia without opioids at all. Now, again, that's not what I'm advocating for here.
Yeah.
But as I started to think, is that something that we should be doing or could be doing? And then I started doing all this reading. Yes, actually, minimizing opioids and utilizing other analgesic adjuncts, right? So in human medicine, they use a lot of acetaminophen. And right now, acetaminophen is kind of a hot topic for veterinary medicine as well. Please note, everyone, I'm not saying that for feline patients, but in our veterinary canine patients, we are looking at utilizing acetaminophen or paracetamol, if you're in the UK, a lot for its additional analgesic benefits. It's a nice analgesic adjunct. The same thing with ketamine. For a while, we kind of thought of ketamine as kind of this older drug, right? And it had a lot of, when you use ketamine at high doses, it's dissociative. So cats on high doses of ketamine, it's usually not a fun time. But what we found is that microdoses of ketamine working at that NMDA receptor actually functioned really nicely as an analgesic adjunct. Same thing with dexmedetomidine. Now, you know I love my dexmedetomidine.
Yeah, totally.
Fantastic drug. And when we looked at the way that it functions as an analgesic, again, none of these drugs, ketamine or acetaminophen or amantadine or anything like that, they're not going to be strong enough to kind of handle an abdominal surgery and orthopedic surgery on their own. That's why the multimodal protocols are so important. And when we talk about creating a really great multimodal protocol for one of your patients, again, whether it be a spay, whether it be an orthopedic procedure or a dentistry procedure, I want you to think about the following things. What opioid should I utilize? What opioid is going to make the most sense for this patient? What adjunct should I utilize? Now, again, your adjunct could be something like ketamine. It could be something like dexmedetomidine. It could be something like midazolam, but remember, we're not utilizing midazolam for its analgesic properties. So what is your adjunct going to be? And then what is my local block for this procedure going to be? So you should be able to answer all of those three questions. And depending on the patient's ASA status or what other things they have going on health-wise, the anticipated level of pain those answers really shouldn't be the same for every single procedure. Sometimes they might, but we want to make sure that we are treating each patient as an individual and each procedure kind of as an individual item that we are looking at. What is going to be the opioid that really makes the most sense for this patient? And sometimes it might be fentanyl, but you know what? Sometimes it might be buprenorphine. So what other adjuncts can I add? And then what local block is going to work the best for this patient?
Okay, let's time travel together. So let's jump in my time machine. We're going to go ahead 5 years. So we're looking at 2030. Tell me about what you see the surgery prep area looking like and how people are behaving there 5 years. That's different from how it is today.
Yeah, I think that probably 5 years where we're going to be at is going to be that our technicians, especially our BTS level technicians, are hopefully going to be utilized even more, and they are going to be kind of crack-a-lacking when it comes to these local blocks. I've kind of made it a personal mission to make sure that every technician that I work with or that I train at one of, our veterinary anesthesia nerds events gets trained in advanced local blocks and kind of these advanced procedures. And I think that is going to be the future. In the same way that your technicians are going to be drawing up propofol for your procedure, they're going to be executing on a local block for your procedure. And I do think we're going to see even better succinct use of pre-visit pharmaceuticals. And, for patients that are fearful, I do think that, for a while, as everybody knows, we kind of talked about it in Anesthesia Nerds, we were just throwing gabapentin at everything and then maybe throwing trazodone. And I think as we start to see how those drugs play in, again, great drugs, but I do think there are other drugs kind of out there as well that we could be utilizing from a behavior standpoint, a low stress standpoint. I think that we're also going to start to see patients and our technicians getting trained in more low stress handling so that overall 5 years from now when a patient comes in for surgery, it's just going to be as smooth and as calm and as pain-free as possible.
That sounds fantastic. That makes me super happy. I really, really love it. Tasha McNerney, you are the author of Pain Management for Vet Techs and Nurses. It is available for pre-order on Amazon. Where can people find you online?
Yeah, so head up the Veterinary Anesthesia Nerds website. We actually just redid our website and we posted a whole bunch of blogs on there about anesthetic oxygen flow, about when and where and how you should clean your anesthesia rebreathing bags, about vaporizer output, about time constants and dead space. We also have a link to our new YouTube channel, which gives different videos on how you can leak test your anesthesia machine, how to leak test a non-rebreather, how capnography works, all kinds of stuff.
That's fantastic. I love the work that you do, Tasha. You make such a difference for people. You're such a wonderful advocate and example for technicians. I love the way you think. You're such an outstanding teacher. Thanks so much for being here. Thanks for being my friend. I just love having you around.
Yeah, let's go to more weddings together.
Let's do more weddings together. All right. And that's what we got. Guys, I hope you enjoyed it. I hope you got something out of it. Thank you so much to Tasha for being here. Guys, she's such a wonderful presenter. She is such a wealth of knowledge. I just fill out pages of notes every time I talk to her because her ability just to lay out information and make it simple and make it understandable and use metaphors and tell stories and give examples, just phenomenal. I just think she's such an incredible teacher. So anyway, thanks to Tasha. Thanks to you guys for being here. Take care of yourselves, everybody. We'll see you later on.